Welcome to the Emergency Medical Technician EMT Assessment webinar. I'm Tom Ryan with Provider Outreach and Education, and I'll be one of your two presenters for today. Today, I'm joined by Mary Sue Gardner, and she's one of our clinical staff. She'll be your second presenter for the day, and we'll go ahead and hand it over in a little while. Today, we do have a little bit of housekeeping to get through. If you want the presentation, I will recommend that you go to our training center right now and download it. The training center is available on the WPS GHA website, wpsgha.com. On the top center, move to the word Training Center. So the top of the screen, right in the middle, you'll see Training Center. Go ahead and select Live Events and locate this presentation. By doing that, you'll be able to download the presentation material. We will either remove that presentation for registration this afternoon, maybe tomorrow morning, sometime within that range. After that, if you want the presentation, you do have to wait for us to upload it onto Encore's. Hopefully that'll happen within a week or so, maybe 2 weeks, and then we'll add a link to the presentation again as materials. So more to come on that. If you have questions, I will take them in chat. We will be monitoring the chat, answering any questions we can. One thing, we are going to try to bring all the questions in at the end. So if we don't get to your question because we run out of time due to the number of pre-submitted questions or other things, we will answer them via email back, and we'll get back to you more on that. Last, we do have a survey which we will be asked to take at the end. The survey is important to us in that it gives us feedback for CMS. It also gives us feedback for ourselves. So please consider taking that survey. I did have Mary Sue throw a link for that right now, but we'll do more with that coming up in a little while. I do want to provide just a really brief disclaimer. I want to let you know that the material is to assist you. The Medicare rules, laws, and regulations do change often, and we will highlight any changes that we know of. But the material is to assist you. It's an educational material only. The answers that we're going to give to the questions for today are based in the question and the information that we have. Why do we say that? Because with the ambulance, one minor detail, what seems minor to you, what seems like something that isn't very big, can change our entire answer. So if we don't know it, it didn't happen, it's not there. So we'll give you what we have today. The current information for rules, laws, and regulations is on the CMS website. Please check that out. We will reference back to that a couple of different times throughout the presentation. What's myself and Mary Sue's objective today? We want to help you determine if a transport meets Medicare's medical necessity criteria. A transport meeting Medicare's medical necessity criteria is something that is billable to Medicare. However, if it does not meet the medical necessity criteria, it is not something that needs to be billed to Medicare. You can bill it, but we'll talk more about that in a little while. So to do that, we do need to define the Medicare transport benefit. This actually came from a question, and I want to make sure we hit that person up and get them the basics before we get too far into that. At that point, I will turn it over to Mary Sue. She will go through the review the necessary documentation components and then give you a couple of documentation examples. So I want to make sure all of that is given to you so that you understand that when our medical review department looks at something, what they're looking for within the documentation and what needs to be there, what is additional information, what is good information, and also what isn't going to help them. We'll talk more about some of those different components. Acronyms. Of course, there are acronyms throughout this presentation. A couple of key ones are here: ABN, ALS, EMT, EMTB, INP, and physician certification statement. I do want to remind you that emergency medical technician, as defined by CMS, has 3 levels. If your state says that a paramedic is above an emergency medical technician and not defined as one, we're going to use the CMS definition during this course. So when we say EMT in general, there are 3 levels. That's why it's built the way that it is. If I'm specifying a paramedic needs to do it, I will say paramedic. If I'm specifying that an EMT basic can do this, we'll say basic. Otherwise, it defines all 3 levels. Medicare's coverage criteria. So this actually came from one of the questions that was pre-submitted, and they did to say, can you define the ambulance transport benefit? The key thing with the transport benefit is that it is a payable benefit but it is a transport benefit. So thank you for putting that into your question directly, because Medicare's benefit is transport only, and we will talk more about where that comes from. But I do need you to understand that if it is not a transport, Medicare documentation requirements don't apply. In other words, if you do a treat no transport, we aren't going to give you advice on documentation requirements for that. It doesn't apply. We're not paying that. So we want to make sure you're well aware of that. One of the key words that comes up a lot is contraindicated. And the word contraindicated is directly in the Social Security Act. The full statement in the Social Security Act says, ambulance services where the use of other methods of transportation is contraindicated by the individual's condition, but only to the extent provided in regulations. Let's break that down for a second. Break it down. Contraindicated. Well, that means that it has to be the only safe means of transport. Why couldn't they go by a different means? Please note within that definition, it doesn't state it's the only available means of transport. It states why couldn't they go by a different means? What's not safe about that? So contraindicated does not consider things like this is the only available means. That is one of the things that we do see within our findings is that it's 3 a.m. and they need to go back to the nursing home where they live, and we called an ambulance because there's no other means to get them there. They don't want to call their family member. The nursing home doesn't have a wheelchair van available at that time, so they use the ambulance. That doesn't make it medically necessary. Now, it doesn't mean that that transport couldn't be medically necessary, and Mary Sue will define more for you on the documentation components that are needed under contraindicated. But I also want to remind everyone that it says use of other methods of transportation. In other words, this is a transport benefit. It's stated in the Social Security Act that it has to be a transportation. If not, it doesn't meet that benefit. So that's also one thing we look for. When it comes into medical review, if there's no transport, they'll automatically deny it, as well they should, as it's not a transport benefit then, it's just a treat no transport, which is a very different benefit for Medicare, okay? So we do want to make sure that you're aware of the term contraindicated and transport, okay? I also wanted to tell you that the section of the Social Security Act that is on this slide is where you will go if you want to read what the Social Security Act says. One of the questions we did get is, why does Medicare not pay for a treat no transport? Well, the answer is the Social Security Act doesn't allow us to, and unless that law changes, we can't pay for it. So with that said, once we have established that yes, it is the only safe means to go, yes, it is a transport benefit. Okay, so now we know that that's happened. We then move on to medical necessity. I'm going to cover just a very basic level of medical necessity. This is what Mary Sue will get into. So not only do you have to consider whether or not they could go by a different means, we also have to look at whether it's a medically necessary transport at the service provided. Wait, what? What does that mean? That means that did they go by air when ground is safe? Could they have gone by ground? Was it medically necessary for that air transport to be needed? Could they have gone by a BLS transport when an ALS was provided? Those are the questions that we do have to ask. Now, I will tell you that when it comes to medical necessity, one of the questions we received was about the advanced beneficiary notice of non-coverage and its usage. We do offer a full course on this, so I don't want to try to navigate through that in this 1 hour time frame. We're not going to make it through the medical necessity portion that comes later if we try to focus just on the ABN. But an ABN is given when an ambulance transport is medically necessary, a transport occurs, and the service is above the level needed by the patient. For me, I have only ever seen this to be required when a air transport occurred, but a ground would be safe. Mary Sue will speak to the fact if she's seen it any other place. That's when we most commonly see an ABN used. Again, we can get more into details if you want that, but you do have to ask some questions there. So what we're really going to look at again is those medical necessity. Is it a transport? One, could they safely have gone by a different means? Wheelchair van, ride share, private vehicles such as their child's, their spouses, etc. And then was it medically necessary at the level provided? Would that have been something that was needed? When we're looking at all of this together, what do we consider? Well, we always consider the assessment at the time of transport. So before the transport occurs, an EMT must assess the patient. For the Part B benefit category, which means they are an outpatient, outpatient, they are not inpatient in a facility. That is the individual the transport is considered individually. Round trips do not exist. This means that if you take them to a hospital, the hospital from a skilled nursing facility is one transport, and the to a skilled nursing facility from a hospital is a completely second transport, and therefore I need two assessments, two different assessments. Why was it medically necessary the second time to go back? Might not have been. By the way, it might not have been. It might have been perfectly medically necessary for them to have gone to the hospital via ambulance. But once they're there and everything is established, now we know more and it might not be medically necessary. We don't know that. We can't answer that for you until the medical record comes in and it gets reviewed. So each leg needs an assessment. Things that you will know at the time of transport. One, why were you dispatched? Now, that may not be what you get to the scene and find. We have seen this many times where someone is dispatched to something, they get there and they're like, this is patient walking around, bags packed, needs to go for. That's not what we thought we were going to arrive. So you still need to do the assessment. There's nothing about that. But we also do want an on-scene complaint. What did the patient say to you? What's going on? Was the patient conscious? So therefore you have a complaint. Maybe they're not conscious and you don't have a complaint. That's all the on-scene complaint is. We also want any bystander information. Again, really basic. When you consider whether or not the transport's medically necessary, consider what did a bystander know? Were they walking down the road and suddenly fell down? Did the bystander say, hey, yeah, my mom is in so much pain because she fell down the stairs and now her hip is hurting? Okay, maybe it's a broken hip. You don't know that for sure, but what you do know is what that bystander is telling you. Is the patient in too much pain to even be coherent? Are they not comprehensive? Does the patient have dementia and they're attacking you? They're violent today. They have dementia and refuse to be put in that vehicle, so therefore you're sedating them. What do we know? That may come from a bystander. Yeah, the reason that they're being so aggressive and they're being violent and they're doing this is because I'm their caregiver and they have dementia. Again, so bystander information. One thing to keep in mind, hospital reports. Hospital reports are great if you're picking them up at the hospital or if it's known information before the transport occurs. One of the things we get sometimes or many times is that we get a hospital report after you drop them off that says this is what supports the medical necessity for a transport. Except how did your EMT know what was in that hospital report before they even got there? Did they have a crystal ball and happen to read it? What's within that hospital report that they knew? Another one is the physician's certification statement. This is definitely a driving factor, and it definitely helps you look at and assess the patient when you're looking at this patient and you're deciding whether or not it's medically necessary. Why does a medical professional feel they should go? Whether it's a physician or sometimes a non-physician practitioner, if it's within, a certain time frame. But I'm not going to get into all of that type of stuff. Mary Sue might get into it a bit more. So we want to make sure we're meeting all of those. Last, and one thing to keep in mind is that inpatient. Remember, if they're inpatient in a facility, your ambulance transport is not separately billable, with the exception of skilled nursing facility consolidated billing and a bunch of rules that apply to that. And we are definitely not going to make it through that today. That's a whole separate 1-hour class just on that one topic. But know that it can be an exception. We do recognize that if they're inpatient in a skilled nursing facility, we know that. On the other hand, someone said, well, they were inpatient in a critical access hospital and sent to have an MRI done at a facility, and then they were brought back to the critical access hospital. That transport is not separately billable to Medicare. The critical access hospital will be billed for the MRI. The transport rolls in to that MRI expense. It's part of it. You can't do the MRI without getting them there. So no, that hospital also cannot bill the transport. So we have to look for all of those different things. So for instance, our medical review department may be looking to say, hey, is there an inpatient claim that would affect this? Or why did this, hit the way that it did? Why isn't it denying or rejecting? Maybe you billed it before the inpatient claim came in and now this is what's happening. There's a variety of factors that will go into that. But those are all things that you definitely need to consider. Part of that, again, is that inpatient bundling rule. Remember that round trips can happen when they are inpatient in a facility. They still need to be medically necessary. They need to be to a benefit. What fits with that benefit? So you can't just take someone somewhere for no reason. And that could be, like I said, an MRI was an example of that, or if there's a CT scan that they need and theirs is broken, or gosh, there's a million other benefits that could be used here. Dialysis, really, what are we looking for? The two biggest hitters for inpatient bundling are hospitals of all kinds and skilled nursing facilities. Again, we recognize that a skilled nursing facility is much more complex. There's a lot more criteria that go into it, but we do have a class on that. And you can watch that out on YouTube. It is an encore video. I was specifically asked if there are things that Medicare does not cover. We'll start with back at the beginning. One, if the ambulance is the only method available, but it's not medically necessary, that's not covered. Remember, it has to be a medically necessary transport benefit. That's why it's contraindicated in the Social Security Act under Section 1861 S7. So that's where we get that from. Patient or provider preference. This is when you go to a further facility than you needed to, because that's what the patient wants. That's what the doctor's ordering. It doesn't have anything to do with a medical need. If it has to do with a medical need, you need to document that medical need, and we'll consider those mileage. But otherwise, we're not going to do that. Physician's office. Now, this one is a very specific question that was asked to us. A physician's office is not a covered destination. This is from the Medicare claims processing manual. We can't cover that. So no matter what you do, it's not going to be paid. Now, if it is an emergency stop, not a planned destination, then we could consider it as an emergency exception, but then the modifier has to be billed correctly to reflect that. So you do have to document why that emergency stop happened and what went on with that. So no, the physician's office itself is not covered. Medicare doesn't cover any other method of transport other than a certified ambulance, and the certification comes from the state, and the state defines what level that ambulance is certified at, whether that ambulance is certified for basic or ALS services, and then maybe additional services such as other items that would fall under SAT or anything like that. That's all there. But it doesn't cover anything like a wheelchair van. Also, Medicare doesn't cover it if it's an excluded destination. I'm not sure what the exact question was with that, because that's literally what we had. So the destination has to be covered. The destinations are all listed in the CMS Internet Only Manual. This is the actual claims processing manual. If it is not one of these, it is not a covered destination. I will also mention that if you put a P for physician's office, that's not covered. But an X is that emergency destination code, and that would be covered. So an X would be covered. Someone asked why we're not covering D for diagnostic or therapeutic site. We are covering D. I'm not sure what you're experiencing. So if you have a claim or you have examples of that, I will recommend that you go to customer service with those, send them the claim number. I can't give you more than that because I don't know what's going on with your claim. But it is actually technically a covered destination. So again, as a destination, if it does not fit these descriptors, don't try to make it fit. It's not going to be payable. Okay? Only these are only payable. Again, P is the exception to that. All right, you guys heard me talk a lot. I do want to do a few more questions, and in the meantime, you're going to see me stop sharing my screen. You're going to see Mary Sue start sharing her screen, and then we will check and see what you have for questions in the chat. So I do think that this is a great opportunity for you to do that. And Mary Sue, I will hand you the screen share while I finish up my questions. All right, what's the main issue the MACs are seeing with documentation? The biggest issue that we're currently seeing is that it does not support medical necessity. no matter what you're doing, it's not supporting medical necessity. And that means that the assessment is not supporting the information, the transport is needed. There are other issues, but they're not as main as the medical necessity. Why are EMS claims denied for services included in payment in other services when the patient transport between two distinct and separate hospitals for a higher level of care? Denial is indicating the EMT transport's included in an inpatient stay. The easiest are, well, the answer to this is complex, but one of the things that we do know is that hospitals and the facilities that they're leaving don't necessarily bill on the same schedule as an ambulance, and this happens all the time. So they have not billed the discharge to tell us that they are not in that particular facility at that time. And so the claim comes in from the ambulance supplier and it denies, saying, hey, they're inpatient here. Well, yes, that's technically correct according to the system. However, it's not really the situation that happens. So you do have to wait and make sure that that gets billed and then check back. There is a way to check that within the eligibility portion on the Part A side within the SecureNet Access portal. A little bit more to come on that later. Now, if the facility does not bill the discharge correctly, this can actually stop you from processing your claim at all, in which case we'll say go back to the facility. And there are times when a discharge status code isn't correctly put onto the hospital claim or the facility claim, anything to do with the ambulance provider, but it does affect your claims. So there's a variety of different reasons that this can happen. So what I would say to you is take your claim number, go back to customer service, and have them figure out what's going on with your claim today. What does WPS consider an emergency situation in which an ABN should not be obtained for what EMS feel is not medically necessary? Okay, so let me just start off with the basics. An ABN is not necessary when an EMT says this transport is not medically necessary. You do not need to get an ABN. That is what is contraindicated. That is that 1861 S7 of the Social Security Act. Could you get an ABN? Absolutely. Here's the thing that happens though. If that was a air transport and it could have gone by ground, which they continue to say, as an ambulance biller, the crew often understands the difference between, or doesn't understand the difference between not medically necessary versus obligation per their wishes. Explain that circumstance. This is where you do need to have your crew understand, one, no matter what they document, obligation to pay, obligation to transport based on a local law, based on some local information that's not medically necessary. These do not require an ABN. Yes, they can give them, but they're only going to complete A through F. They don't have to have a patient choose one of the three options. They don't have to have it signed. Don't do that. You don't need to do that. On the other hand, if it is truly an emergency situation, they should never be giving an ABN. So your crew has determined this isn't medically necessary. They need to bill that accordingly. It's not part of Section 1861 S7, which means that they will append a GY as the biller. You would append a GY. The crew just needs to tell you it's not medically necessary. Therefore, it falls into contraindicated. The documentation just needs to indicate it's not medically necessary. If you choose to give an ABN, that's great. They can give an ABN. They complete items A through F. And then you would append a GX saying, I gave an ABN, but it's still not medically necessary. Doesn't have anything to do with, patient liability or anything like that. Okay, so hopefully that helps kind of explain it. The key thing from that one is it is not a medically necessary transport. Why can Medicare dictate who can be transported via 911, and why should an EMT be allowed to deny care or transport? Well, a 911 call can come in for a variety of different reasons, and in some areas, 911 is the only way to get an ambulance there, regardless of whether or not it's medically necessary. So based on the Social Security Act, which is a federal law, it states that we do have to have written proof of medical necessity. That's what the documentation is all about. So the law is what drives this. There's a federal law driving this. A 911 protocol could be state or local or whatever, but it does not override the federal law. And that's why the EMT can say this isn't medically necessary and you would bill it. Now, here's the thing that can happen. A patient absolutely has the right to appeal that denial. That's fine. Just bill it, let the patient appeal it, okay? And then there was a question on how to bill a treatment, no transport. Quite simply, it is an A0998. It is not a payable code by Medicare. Our medical review department would not look at that. There is no documentation requirements for Medicare for that, but we would recommend, or we would encourage you to include modifier GY, so the A0998 with modifier GY. This just stops it from processing in the system and kicks it out that much faster for you. With that said, I'm going to hand it over to Mary Sue and allow her to continue the presentation. Mary Sue, please go ahead.
Thank you, Tom. Before I get started, I would like to verify with Tom that you can see the presentation on my end and that my audio is good.
I can see it and I can hear you perfectly. You're ready to go.
Perfect. Thank you. As Tom mentioned, my name is Mary Sue Gardner, and I'm going to be your presenter for the second half of the presentation. I am a clinician, so I'm a registered nurse in the Provider Outreach and Education Department, and I'm going to focus on the documentation to support the coverage criteria that Tom just talked about. Let's start with some documentation basics. So regardless of the type of ambulance transport that you're doing, these are some basic things that you need to have in all your documentation. They include the fact that all ambulance trips need to stand alone. So the documentation basically in this is one trip cannot be used to support another trip. So you can't say refer to documentation from another trip. Each trip that the ambulance makes has to stand alone. You must support medical necessity. Now, Tom talked about medical necessity quite a bit. And again, medical necessity for ambulance services, that means that transportation by any other means would be contraindicated, would be detrimental to the health of that beneficiary. That's why your documentation really needs to detail the patient's condition to support the need for transportation by ambulance. So loaded miles is next. As Tom mentioned multiple times, this is a transportation benefit. So we need to see some sort of documentation of the actual loaded miles. This could be odometer readings or documentation of miles from point of pickup to point of drop off. However you obtain those loaded miles is how you obtain those, but somehow we need to see those loaded miles. Other documentation has to include run sheets, and we're going to get into this a little more, but it's probably one of the most critical pieces of documentation for your ambulance trip. The run sheet generally contains most of the information that's needed to support the ambulance trip as medically reasonable and necessary. Moving on, physician certification statements, if they're applicable. So non-emergent ambulance transports that are either scheduled or unscheduled or repetitive all require physician certification statements. The information on the physician certification statements can be found in the Code of Federal Regulations, 42 CFR, that's 410.40. And Tom just put a link to that into the chat for you if you would like to have that. Here you're going to find the information on when you can have a non-physician certification statement or when it must be completed by the actual physician. Again, and Tom placed that into the chat. Next, if you're traveling outside the range of the closest available facility for that patient, then your documentation needs to support why. Are services at the closest facility not available? Are there no beds available? Are they closed to trauma or on diversion? Do they not have the specialist maybe needed for the patient's condition, et cetera? These are just some examples of what would make it that you would have to go to a different facility. Remember, any mileage beyond the nearest appropriate facility capable of providing the necessary treatment for that patient's condition those mileage or those additional miles may be denied if there's no justification provided. And finally, all of your documentation needs to be signed and dated. So let's move on and talk a little bit more about some of these components. I said before that the run sheets are probably one of the biggest pieces of information, pieces of documentation that are necessary to have in your overall documentation. So that's because generally a run sheet contains most of the documentation that supports medical necessity for the transport. Now, not all run sheets are the same, but the information we need to help support your transport as reasonable and necessary that we usually get from a run sheet includes all this information that's on the screen. So what's the complaint that was reported by dispatch? Why was the ambulance called out? We need details of that patient's condition and chief complaint. What do you know about the patient when you get there? What's their chief complaint or the complaint of the caller or observer? What quick things can you document and tell us about that patient's condition when you arrived? What services did you render? You may have to include additional information, you know, on separate run sheets or in additional pages that go with your run sheet. That may include, like, if you do ECG readings, you might print that out and it might be included as additional piece of information to your run sheet. Ventilator information is another one. Any type of procedures that are done, those may, you know, sometimes the documentation for these things is more than can be on your additional run or on your run sheet. So additional pages to your run sheet may need to be included. Moving on, point of pickup and drop off. Tom talked about the modifiers that go along with this, but as a component of your documentation, we need to see where these things work. If it was the side of the road, what's the closest intersection, the zip code, or mile markers if it's like on a highway or interstate system, and then what direction were you heading, you know, to that closest mile marker. What are your loaded miles? I spoke about this earlier. Loaded miles only include the miles where the patient is on board, so not the miles from the station to the point of pickup and then to the point of drop-off, only where you picked them up to where you're dropping them off. Also, if there's no transport, there's no miles to report, and Tom already kind of talked about that. Other things on the run sheet, how did you respond to the call? Did you go lights and sirens? Was it emergent response? Maybe it was a emergent response, but no lights and sirens. Were you called out, you know, as an emergent response, or were you called out as a non-emergent response? Was there any prior aid rendered, and who rendered that aid? This could be by bystanders. It could be by family, a police officer responding to the call, maybe a firefighter that got there first, etc. So if there was aid provided prior, document that and document who did that. Next, trauma triage criteria. So that's a determination of if your patient should be transported to the highest level, like a trauma center, or to a lower level of care. And that's based on the patient's condition. Some people use a color scale. So high risk is usually red. Those patients usually have a Glasgow coma scale of less than 6. They're unable to follow commands. They have respiratory rates that are generally less than 10 or greater than 29. They have pulse ox that's under 90%. There can be blood pressure or heart rate parameters as well. So somehow let us know the trauma triage level that you're providing. Medications. This includes a list of medications that the patient is on, if you know those, as well as any medications that you administer to this patient. Procedures. What did you do for the patient? What procedures were provided? Thinking about ALS assessments and procedures, make sure you are documenting what you did. And of course, we'll get into those a little bit more coming up as well. Then there are things like vital signs, crew information. If you're going to report ALS level of services, do you have the right crew on board? Did the right crew members sign for such transports and also sign for what services that they provided? And destination as well. So remember, in your documentation of your run sheet, use your senses. What did you see? What did you hear? Like, were there rails in the lungs? What did you smell? Does the patient have fruity breath? This could be indicative of diabetic ketoacidosis or even liver failure. What did you feel? Is there displacement of bones? Are there palpable pulses? Generally not what did you taste. Please don't taste things, but sometimes the smell can cause a taste. So that's something you're going to want to describe in your documentation as well. And just going back to patient complaints, does the patient complain of a certain taste? Do they taste metal or something soapy? This could be indicative of poisoning in some cases. So moving on, let's talk about some additional docs. All right. Again, we discussed this a little bit, but we need to see documentation was to the nearest appropriate facility. If not, then why? Was it patient, family, or physician preference? That's not a legitimate reason to go beyond the closest appropriate facility. Assignment of benefits should also be documented. An assignment of benefits, this is your legal agreement that's signed by the patient or their authorized representative that directs them to bill Medicare, in this case, to pay for the ambulance services that were provided. And finally, signature attestation statements, if those are applicable. So moving on, let's talk specifically about the physician certification statement. Ambulance providers are required by federal regulation, and that's in that 42 CFR 410.40 that Tom gave you the link to earlier. You're required to obtain a physician certification statement from the patient's attending physician or for non-emergency ambulance transports, either scheduled or not scheduled. And that's before you submit a claim to Medicare. So again, that's for your non-emergency ambulance transports, whether they're scheduled or not scheduled. A physician certification statement is required in advance for those non-emergency services. So what exactly is the physician certification statement? The PCS, or Physician Certification Statement, is a statement that's signed and dated by the beneficiary's attending physician, which certifies the medical necessity provisions are met. So the statement doesn't need to be a standalone document. There are no specific forms that are required. I will show you an example of a form that we have that may help you. While there's no specific Medicare approved form, you know, the PCS information on the form used must comply with Medicare guidelines. So what information needs to be on the form? You need to have the patient's name. You need to have the dates of the ambulance transport or transports. You need to indicate what the patient's medical problem or condition is that necessitates the ambulance transport. So the information on the physician certification statement must include like specific explanation as to why other means of transport would endanger your patient's health. There needs to be a signature of that authorized individual, and it needs to be dated. So Medicare regulations require that the services that are provided or ordered be authenticated by that author. And that's why we harp so much on the signatures and the signature for each entry. And that's got to be legible, and it's got to include the practitioner's first and last name. So I said we have an example, and it looks like what's on the screen, but that's kind of blurry. You know, it was just a little screenshot. But let me show you what we have on our website. It's just going to take a second to open. So we have a physician certification statement that you can download and present to your physicians that do non-emergent ambulance transports and have to certify for those. If you were just to come into WPSGHA.com and not using the link, because maybe, you know, a couple days down the road, you delete this PowerPoint. You don't have that. Where can you find that? Couple options. You can go under Tools, All Tools, scroll down here to All Forms, and then under Documentation, the Physician Certification for Ambulance, and then Download. Let's say you're not one that likes to navigate through a bunch of different clicks. You can just type in Physician Certification and look to, see what comes up. I'm going to just type in PCS, Physician Certification Statement, and it's going to take you there. Download this. It'll open for you. You can input the information electronically. You can print this and handwrite it in. It is a usable form, so you can, you know, type within it. But if you even just use our example and adopt something in your own facility, or encourage your physicians to adopt something similar to this, it is really going to go far in making sure you have all the information to show us why services via ambulance are reasonable and necessary, why they would be contraindicated for this patient to go by another means of transportation. Because you can see as you go through this, are there issues with the person not able to sit, so maybe they couldn't even sit in a wheelchair? If there are, why? Are there special handling or positioning because of something going on? A fracture, an ulcer, etc. So they can't sit in a wheelchair van, or they can't ride, you know, in a car. Do they have decreased level of consciousness? What are things that the physician wants you as the EMT to monitor for? Or what kind of interventions do they want you to give to this patient? Seizures, ventilators, IV medications, EKG monitoring, et cetera, et cetera. The list goes on. So I really highly encourage you to go out and take a look at this. And like I said, you're welcome to use a form such as this. And if you don't want to use our form, it's not a requirement. Adopt something in your own practice that's similar. All right. So as we move on, let's talk about the EMT assessment documentation. So we want to focus a little on the assessment, because that's why we're here. When it comes to the EMT assessment documentation, this is your place to shine as the provider of the services. Show us the details of the physical assessment findings. Again, use your senses. Tell us what you see, what you hear, what you feel, what you smell. Documenting using your senses also fills in things like vital signs, neurological status, so your Glasgow Coma scales, respiratory status, etc. What are you seeing? What are you hearing? What are you feeling? What are you observing on that patient? What did you observe at the scene? Are your observations of the patient's condition different than the reason that you were called out? So while documenting your assessment, bring in the relative history of the patient if you can bring that in. What meds are they on? Do they have a history of disease or surgery that's being exacerbated by their current condition? Let's move on to some of the specifics in your assessment information, and let's talk about some of those things that are required as part of an assessment. If you're doing ALS assessment, there are some things that must exist. The ALS assessment must be performed by an ALS crew as part of that emergency response. So it must be necessary because of the patient's reported condition at the time of dispatch. And that reported condition was such that only an ALS crew would be qualified to perform the assessment. So in other words, an examination of the patient's condition, where there is things like severe trauma, there's chest pain, there's shortness of breath. These are conditions that warrant the advanced diagnostic and treatment capabilities of someone like an EMT paramedic. Assessment of A, B, C, D, E, airway, breathing, circulation, disability, which includes neurological status, and exposure, which could be environmental and physical examinations, and if any interventions are warranted. So moving on, an ALS intervention is a procedure that's done in accordance with your state and local laws, and it's required to be furnished by the ALS personnel, so EMT intermediate or EMT paramedic. Some examples may include things like endotracheal intubation, manual defibrillation, IV access, medication administration, cardiac pacing, chest compressions, even your 12-lead ECG and interpretation, etc. These are some examples of what falls into ALS intervention. So let's break these down a little more into what's needed for specific levels. When it comes to the ALS-1, for ALS-1 to be billed, there needs to be transport by ground ambulance vehicle. There needs to be medically necessary supplies and services provided, as well as either. Remember, these are key words here. ALS assessment by that ALS personnel, EMTP, EMTI, or the provision of at least one ALS intervention. So those things we talked about on the last slide, EKG or ECGs, EKGs, however you say that, defibrillation, IVs, IV access, intubation, etc. As we move into ALS-2, when it comes to ALS-2, the things that we're going to look for in your documentation also include that ground transportation, medically necessary supplies, as well as the administration of at least 3 medications by either IV push, IV bolus, or continuous infusion, or the provision of at least one ALS procedure. So I'm going through the coverage criteria, but I'm focusing on what needs to exist in your documentation, because we're going to examine your documentation on medical review and make sure these things exist. So we have to make sure your billing matches your documentation. If we can't find it in your documentation, we can't pay you at the level of service that you put on your bill. ALS procedures. I'm going to highlight some of those ALS procedures again. I've spoken about a few as examples, and I just want to give you a list of what types of things can be included. So we kind of went through the manual defibrillation, if you're doing cardioversion, intubation, if you're doing central lines, cardiac pacing, chest decompression, surgical airways being put in, if you're doing the interosseous line, and maybe there's going to be some pre-hospital blood transfusions that might be able to be done. So, and then there's examples here on this slide of what some of those types of blood transfusions may be. The ALS personnel. So finally, I just want to highlight who's considered ALS personnel. And I've already alluded to this, but I just wanted to make sure it's in your presentation and available for you. So the EMT intermediate or EMTI and the EMT paramedic or EMTP. These individuals are trained to perform advanced techniques and administer some medications. That's why we always check that the correct individual is providing the care that equates to the level of service provided. So if your documentation doesn't support these individuals upon review, it would be hard for us to agree to pay you at the level of service if it wasn't supported in your documentation. So we have a little bit of time, and I want to bring in some documentation examples and go through a few things with you to just highlight what we see upon review. I'm going to pull this into the screen. I'm going to ask Tom to verify really quick that he is seeing documentation example on the screen. Tom?
Yes, I am. You're ready to go.
Perfect. Thank you. Sometimes it doesn't always work when I pull things in just the way the screen shares. So this is actual live documentation that we received. So as we do a review and scroll through some of the information, what are we going to look for? We're going to look at what the triggered condition at dispatch was. So what was the need? And this happens to be a review for ALS transports. So what was the need for the ALS? And this call came in for generalized weakness and hematemesis, so vomiting blood. If we scroll down through here, you can see a little bit more information on some of the treatments that were administered and by who. So we have provider information here. I'm going to scroll down to page 2 here real quick and just show you the narrative, because in this, we have the reasoning that this ALS was called out. They were called out for someone spitting up blood and feeling weak, and they arrived to find a 91-year-old female that was lying in bed awake. The patient was alert and oriented ×3 with complaints of increased weakness that started that day. They observed some Kleenex with blood on them. The patient states that they felt that, the blood in their throat and coughed it out. The patient has no history of bleeding disorders, pulmonary embolisms, etc., not on any blood thinners, no chest pain, shortness of breath, etc. So we're getting assessment in here. We're talking about what we're hearing, what we're seeing, what we know about the patient's medications, what the patient is complaining about. We're doing stroke scale, which was negative. We have a little bit of information about the patient actually is not so weak that they couldn't stand up, because this patient was able to stand and able to get onto the stretcher themselves. So again, this is all information that gives us good information about the overall assessment. We know that there was intervention of 12-lead EKG and IVs. And then they further support that in the documentation down here about what they see in the 12-lead, and that the IV was successful on the second attempt. So there was 2 attempts at the IV. And all right, we know who did this. I know who did this before I redacted this information, and I could see that it was performed by either the paramedic or the EMT. And there was also a student present in this one as well. So again, what was the trigger condition at dispatch? And that was that weakness and spitting up blood or vomiting blood. Who were the personnel? Do we have the right personnel for an ALS transport and treat? And we did have EMTI and EMT paramedic. What's the level of service? So ALS assessment and or one ALS intervention or procedure. So this claim, we were looking to make sure it supported an ALS level 1. So we did have the procedure, we did have an assessment. We actually had 2 procedures. So remember that part of your ALS assessment includes A, B, C, D, E, airway, breathing, circulation, disability, and environment. So part of the assessment for airway, you're going to assess their respiratory effort. You're going to assess for any obstructions. Is the beneficiary able to talk? Do they have a patient's airway? You can see we have some of that information in the fact that the patient responded, the patient verbalized, whatever. So we know that we have a patent airway at this time. Let's move on to breathing. Looking for CO2 levels. So did we do SpO2 levels on this patient? And the answer was yes, that was up here earlier in the documentation. So we know that they're 91% on room air, etc. So you can go through, all the rest of the ABCs, but this is part of your overall assessment. Circulation, you're assessing for adequate circulation. The patient's level of consciousness, the skin color, pulses on, in the extremities, blood pressure, pulse pressure, etc. These are all things that are helping to assess, your patient's ABCs. They did a Glasgow Coma scale, so that's listed here. So that gives us part of that D, that disability, that assessing their neurological assessment. Things like level of consciousness, we already know they were alert and oriented ×3. Motor skills, those can be used as well. And then environment, checking surroundings for safety. Are we in a safe environment? This is really important too when you are in situations where you're doing an emergent response and, if it's on the highway, and making sure that you have a safe scene and that your treatment of the patient is safe. So, if you have to move a patient in a manner that you would not otherwise move them because of the situation at the scene, make sure you are documenting that as well. Again, we talked about the interventions and the IV initiation. They're performed, the ECG. If there's medication administrations, if they're oral or aerosolized, if they're getting nebulizer treatments, etc., we would need to know that. And again, we have most of this information on the first couple pages of this patient's run sheet, and we found all the information that we needed. Other things, we have the loaded miles. We have information about how the patient was transported, etc. We again have information that authorizes the the ambulance service to go ahead and bill Medicare. And we had a signature by this patient or by this patient's family that acknowledged that as well. And then as I scroll down, then the rest of the information just contains stuff about signatures and signature requirements. Here's additional information as part of the run sheet. So where I talked about additional monitoring, if there are ECGs that are done and you want to attach that information, that those may be additional pages, etc. So as we go down here, you know, again, we conclude with attestation statement by ambulance and crew, and we have that information. So this was a good example. Now I'm going to switch gears and switch to another claim that maybe is not as good. So this was a claim that, and I know we're right at call end time, so if you need to jump off, please do. I apologize, but I really think it's important to give you just a few more pieces of information before I give the closing remarks. And I thank you for giving me a few extra minutes here. But this was one that was called out as an ALS assessment as well. And we have an 87-year-old hip, groin, and wrist pain. Priority was a tier 2 immediate response without lights and sirens. The call type was ALS in this. So they said an ALS assessment, you know, this is part of their documentation. ALS assessment documented. They said yes. There's no ALS interventions that are listed. The patient's condition, you know, was pelvis and wrist pain, and that the patient was confused. They had some pain from the fall. As we scroll on down, I'm just kind of highlighting some of the key things that are in this chart for the sake of timing. 87-year-old female fell from standing yesterday, now has hip, groin pain and wrist pain. Caller, it says caller has dementia, will cooperate. I think caller was stating that the patient has dementia, but it's cooperative. Again, they didn't need to respond lights or sirens. They're saying an ALS assessment is warranted in this case. It was non-emergent. Here's a patient's spinal acuity was a status green. It was family choice of the reasoning for the destination, which is fine if that patient is still if that destination is still within the parameters, locality of that ambulance supplier. Here I live in Omaha, Nebraska, it seems like we have a hospital in every corner. So, you know, 2 blocks one direction or 2 blocks the other direction could get you, you know, to any hospital that's capable of treating the patient. We know information about the people in the ambulance. We have emergency technician, EMT, but we don't really know the level of this person. It just says EMT, so we would have to assume this is basic. And we also have paramedic. We also know we have a student in this case. So as we scroll on down, again, hip pain, wrist finger pain, we got a little bit of the patient's history. And here's where we do some basic vital signs of this patient, a pain assessment of this patient. We've marked out where the pains are, no cardiac arrest, etc. Again, the assessment as follows. They kind of go through and give, you know, a head to toe assessment of what they've seen and vital signs. No medication was administered. Patient was monitored during transport. And then down here, they even say BLS support was provided, but they billed this as an ALS. So while the treatment itself and the need for the ambulance was medically necessary for this patient, the level at which they billed it was not. So I know that takes us to the end of our time, and I thank you guys for staying on, those of you who were able to stick with me. I thank you for your additional time. I'm just going to give some closing remarks, and in your PowerPoint and on the screen are some resources that are really good resources for you to be aware of. I highly encourage you to go out and take a look at some of these additional resources we provided for you. I know there was some questions in the chat, and if Tom was not able to help with those or answer those, we'll make a list and we'll send those out. If it's pertinent to everyone, we will send the list out to everyone. If it's something that's specific to that provider that asked, we may just respond to that provider. But we will get those answers out to you. Be assured that your questions will not go unanswered. In your mailbox right now, you should have an email. Don't delete that email without reading it. It's your certificate of achievement. It is your information if you need to provide this documentation, this email to your ambulance certifying entity to obtain CEUs, you can do so using this email. So make sure you pay attention to that. If you have follow-up questions and it doesn't come back out to you as an answer that was asked during the presentation, so if you think of something in the next couple of days, go ahead and send that in to us. You can send it to wps.gha.education@wpsic.com. If you have the PowerPoint presentation, you can just click on the link that's in the presentation. It's going to, start the development of your email. And make sure you put today's topic. Make sure you put, something like ambulance assessment or something like that into the subject line, so we can be sure that Tom and I get that and we get that answered for you. And send those in within the next 7 days. If you happen to have a question that is related to your claims or claims processing, we cannot answer those. Those have to go through customer service, and we by no means want you to get in trouble for trying to submit protected health information or PII through an email. So if you need to send something in, there are secure ways to do that through the customer service. So you would have to do that way. Plus, Tom and I don't have access to the systems to look that information up. In your chat is a link to the survey, and when I close out this webinar, you're going to be redirected to a site that you can take our survey. We value your opinion, we value your thought, but the best part about taking our survey is it is your opportunity to not only tell us how we did, if this is valuable to you, but what you need in the future. We need to know that so we can continue to provide the best education possible to you. So if there's something that spawns off of this education, let us know that. And then finally, these are just a few changes that we have made as a result of those requests that come through our survey. So take a look at those at your leisure. And finally, on behalf of Tom and myself, as well as Medical Review, we want to thank you for your participation in today's event. And for those of you who are able to spend a few extra minutes with us, we appreciate you giving us your time. This concludes our webinar, and you may now disconnect.